Introduction. Bromide has been a significant anti-seizure medication, first recognized in human medicine in the 19th century. Despite being largely replaced by newer anti-seizure medications ASMs due to its side effects, bromide remains in use in veterinary medicine for managing epilepsy, particularly in dogs. Over 30 years of clinical application has provided insight into both the efficacy and the potential complications of bromide therapy in epileptic patients. The goal of this review is to provide veterinarians with a comprehensive understanding of bromide, covering its history, mechanisms of action, pharmacokinetics, efficacy, adverse effects, and possible drug interactions, by highlighting both the positive and negative aspects of bromide. This article seeks to help clinicians make informed decisions when using this ASM in veterinary practice, especially when dealing with refractory epilepsy or as an alternative to more common ASMs like phenobarbital. Historical perspective. Bromide was first used as an anti-seizure medication in human medicine in 1857 by Sir Charles Lockyer. He employed bromide to treat young women with seizures linked to the menstrual cycle, which he termed catamenial seizures. Bromide's anti-seizure properties gained more attention in the following decades and, by 1861, it was recognized as the first effective ASM in humans. Despite its success, bromide's popularity declined in human medicine after the introduction of phenobarbital in 1912, which proved to have fewer sedative effects and more favorable side effect profiles. In modern human medicine, bromide's role is limited to specific cases, such as refractory pediatric epilepsy. In veterinary medicine, bromide found its way into clinical practice much later. In 1991, Schwartz, Porsche, and Jurgens introduced bromide as an effective add-on therapy for dogs with refractory epilepsy. Since then, its use in both dogs and, to a lesser extent, cats has been well documented, with bromide primarily serving as a second-line treatment for dogs that do not respond well to phenobarbital alone. Mechanism of action and pharmacokinetics. Bromide's anti-seizure effect is based on its ability to pass through neuronal chloride channels, promoting hyperpolarization of the neuron and enhancing the inhibitory effects of gamma-aminobutyric acid GABA. The accumulation of bromide in the neurons increases the seizure threshold, making seizures less likely to occur. The effect of bromide is synergistic with other medications like barbiturates, which also promote chloride influx through GABAergic pathways. One of the distinct advantages of bromide is that it does not undergo hepatic metabolism, unlike many other ASMs. This is particularly beneficial for patients with compromised liver function, as bromide avoids hepatic toxicity. Instead, bromide is eliminated by the kidneys, which results in a long half-life, up to 46 days in dogs. This extended half-life means that steady-state serum concentrations can take several months to achieve, although therapeutic levels can be reached earlier using a loading dose. Dosage and administration. Bromide is usually administered as potassium bromide, KBr, and can be used as monotherapy or as an add-on therapy with phenobarbital. Sodium bromide NaBr is another option, though it is less commonly available and primarily used in cases where potassium administration may be undesirable, such as in dogs with hypoadrenocorticism. For dogs, the typical maintenance dose of potassium bromide ranges between 20 to 40 mg/kg day when used as an add-on therapy, and between 30 to 40 mg/kg day for monotherapy. In some refractory cases, doses as high as 50 to 80 mg/kg day have been used, though this is generally considered excessive. A key advantage of bromide is its long half-life, which allows for once-daily dosing, improving owner compliance. Loading doses can be administered to achieve therapeutic levels more quickly. Protocols for loading doses vary but typically involve giving 600 mg/kg over several days. The use of a loading dose is associated with a higher risk of gastrointestinal upset, and patients receiving a loading dose should be closely monitored for side effects like vomiting or diarrhea. Efficacy of bromide in canine epilepsy. Bromide's efficacy has been well established in the treatment of refractory epilepsy in dogs. As an add-on therapy, studies have shown that bromide can reduce seizure frequency by over 50% in 50% to 83% of cases. In some cases, bromide allows for a reduction in phenobarbital dosage or even complete withdrawal from barbiturate therapy. One study reported that in 19% of cases, phenobarbital was successfully discontinued after bromide was introduced. The use of bromide as a monotherapy is less well documented, but one study reported that 52% of dogs treated with bromide alone became seizure-free. However, phenobarbital remains more effective overall, with 85% of dogs in the same study achieving seizure control when treated with phenobarbital alone. For cats, bromide is not commonly used due to the high risk of adverse effects, particularly respiratory issues such as eosinophilic bronchitis. The limited studies available on cats indicate that bromide is less effective and less tolerated compared to dogs, and its use is generally discouraged in feline patients. Adverse effects. The adverse effects of bromide can be divided into neurological, gastrointestinal, and other systemic issues. 1. Neurological effects. Sedation, ataxia, and paresis are common side effects, particularly at higher serum concentrations. Some dogs may also experience irritability or restlessness. These effects tend to be more pronounced when bromide is used in combination with phenobarbital. 2. Polyphagia and weight gain. Many dogs on bromide experience increased appetite. In some cases, this can lead to significant weight gain or behavioral issues such as garbage ingestion or pica. Polyphagia is more common when bromide is used in combination with phenobarbital, affecting up to 80% of dogs in one study. 3. Polyuria and polydipsia. The frequency of polyuria and polydipsia in dogs treated with bromide is debated. While some studies report no significant increase in these symptoms, others have noted that they are common in dogs receiving both bromide and phenobarbital. 4. Gastrointestinal issues. Vomiting and diarrhea are among the most frequent side effects associated with bromide therapy. These are usually mild, but can become severe enough to warrant discontinuation of the medication in some cases. Dividing the daily dose or administering bromide with food can help reduce the risk of gastrointestinal upset. 5. Respiratory effects. In cats. In feline patients, the most concerning side effect of bromide is eosinophilic bronchitis, which can be life-threatening. Coughing is the most common symptom and can occur weeks to months after initiating bromide therapy. This side effect has led to the general recommendation that bromide not be used in cats. 6. Bromide toxicosis. Bromism occurs when bromide serum concentrations become too high. Symptoms include depression, ataxia, paresis, and stupor. Treatment involves reducing the bromide dose, administering intravenous saline to promote excretion, and, in severe cases, using diuretics like furosemide. Bromism is dose-dependent, but some dogs may show signs of toxicity even at relatively low serum concentrations, highlighting the importance of regular monitoring. Monitoring bromide therapy. Regular monitoring of serum bromide concentrations is crucial for ensuring therapeutic efficacy while avoiding toxicity. Due to bromide's long half-life, it can take 2 to 3 months to reach steady-state levels, but serum concentration should be checked earlier if loading doses are used. In stable patients, annual monitoring is usually sufficient, but more frequent assessments may be needed if there are changes in seizure frequency, dietary chloride intake, or if signs of bromism develop. Bromide serum concentrations between 1,000 to 2,000 mg are considered therapeutic for most dogs, though the exact range can vary. It is important to note that bromide's pharmacokinetics can be influenced by the patient's diet, particularly their intake of dietary chloride. High chloride diets can lead to increased bromide excretion, potentially lowering serum concentrations and reducing efficacy. Similarly, low chloride diets can increase bromide concentrations and the risk of toxicity. Drug interactions and dietary considerations. Bromide does not undergo hepatic metabolism and has no significant interactions with most other ASMs. However, its elimination is heavily influenced by chloride intake, making dietary management a key component of bromide therapy. High chloride diets or intravenous saline administration can rapidly decrease bromide serum concentrations, potentially leading to breakthrough seizures. Clinicians should advise owners to maintain a consistent diet for their dogs and avoid sudden changes in chloride intake. In cases of bromide toxicity, increasing chloride intake can help enhance bromide excretion and reduce serum levels. Loop diuretics like furosemide can also be used to promote bromide elimination in emergency situations. Discussion and future directions. Bromide remains an important tool in the management of canine epilepsy, particularly for dogs with refractory epilepsy or those that cannot tolerate phenobarbital. Its long half-life and relatively low cost make it an attractive option for long-term seizure management. However, the challenges associated with bromide therapy, including its narrow therapeutic range, dietary interactions, and potential for serious side effects, require careful monitoring and individualized treatment plans. Future research should focus on better defining the therapeutic ranges for bromide, particularly in monotherapy, and exploring ways to minimize its adverse effects. Studies on bromide use in specific populations, such as senior dogs or those with renal impairment, would also be valuable in refining its role in veterinary medicine.